All right. Good morning, everyone. I guess it is
It's
still
okay.
morning. I
Thank you.
am going to go ahead and um, uh, essentially keep the intro short this morning and just turn it over to Krista as your, I guess this is the last primary care subgroup meeting, right, Krista?
I think we'll want to do one. We have one set for May,
Okay.
where we might use that for questions and answers on the application if it's out at that point. So yeah,
But obviously, we hope this will be the one where we kind of finalize everything and get it together so the
yes,
appropriate authorities can approve whatever we do. So this is an important one.
yep.
So having said that, I am going to go ahead and turn it over to Krista and let her take over, and we will get going with the EQIP Primary Care subgroup meeting here on April 17th, 2024. Krista, it's all yours.
Great, thank you. So good morning, everyone, and thank you for taking the time, of course, to attend today's EQIP Primary Care Subgroup meeting. We have some exciting updates to share today. Yesterday, you should have received the slides and the eligible zip code list. I know MedKai sent that out yesterday, so we will discuss and touch on that during the presentation. If you did not receive either of those, of course, please reach out to Jean. Um, um, a quick, I'm going to do a very high level overview on the background because I know folks are very familiar with this. So as we know, CMS approved a one-time reversal of the MPA savings component, and the state set most of this aside to fund investments in primary care in Maryland, including $19 million to expand access to primary care in underserved areas of the state. And we see EQIP as supplementing MDPCP, I think, and really as an on-ramp to MDPCP participation, depending on what that looks like under the AHEAD model. As you know, this program will be implemented in certain urban and rural geographic areas of the state. We will ask organizations to apply. The application will be distributed in May, fingers crossed, and those organizations will receive the funding, and we will score those applications based on set criteria, which we've discussed in past meetings and we'll touch on again today. Okay, so that was a very quick high-level overview. I think we want to get into the meat of the meeting, and so we're going to move on to the program updates. So this is an overview of the focus area selection criteria. As you know, we are using HPSA as a measure of primary care supply and PQI and ADI as measures of primary care need to determine where in the state is the greatest need. So we've worked very closely with our team here at HSCRC and our contractors to hone in on this criteria. And the zip code list that we sent out is what we believe to be the final list of eligible zip codes. And here we have, if folks have not had a chance to review the Excel doc, please do so and reach out with any questions, but a couple of summary points here for folks that haven't looked. There are 20 zips in tier 1, which is the higher need area. We're considering the higher need area, and 34 in tier 2, which is the high need area. So you can see here how Maryland compares to tier 1 and tier 2 in terms of ADI national rank and decile, and as well as a PQI composite score per 100,000. So these numbers fell out, I think how we had hoped to see them. So these areas really are the greatest areas of need. And tier 1 and tier 2 represent close to 20% of the population of Maryland. So we think that's a good target. So we can see here visually how those ZICTAs appear on the map with a distribution across the state that we think is appropriate and captures the areas of the state that we have heard and know there is the highest need for new primary care access in these underserved areas. So again, Allegheny Garrett, some in Washington, of course, Baltimore City, a few up in Cecil, 2 zip codes in Prince George's County, as you can see on the Excel doc, and then get the Eastern Shore with Dorchester, Somerset, Wicomico, and Caroline. So I think, this is a pretty good distribution, and, we'll be interested to hear folks' thoughts on this, maybe at the end of my presentation. And then we have the MDPCP practices here, so you can see how those are distributed according to around those focus areas. So there's some overlap, of course, in Baltimore City, but not a ton in the other areas, a little bit up in Washington. I don't want to go too fast, but I'm going to keep going. And just to touch on here, the scoring criteria. So we have the focus areas selected. We'll be putting out the application in May, and we'll be scoring the applications based on this criteria. We took into consideration all of the feedback from the last call, and we decided to settle on this criteria and these points. And we think that this is a pretty fair set of criteria. And when we send out the application, we will include this as well, so folks can kind of see where where the points will fall for each of those sections. Okay, so there's been a couple changes to the funding streams, and so I'm going to talk through these. The infrastructure payment, just to be really clear, is available for the first 2 years with the potential for expansion to years 3 to 5, depending on the applicant. So that funding may, again, depending on the applicant, may be available for up to 5 years. And those annual payments we made to practices in the last quarter prior to each program year. So when we send out the application, there'll be a set of questions that'll match up with the criteria. And there will also be a financial template whereby the applicant will indicate how much funding they need for infrastructure, how much, that is the only payment that is not set by HSCRC. The beneficiary payment and the shared savings payments will be set by HSCRC. So the applicant will have the opportunity to say what they need, how much funding they need, et cetera, et cetera. The beneficiary payment, again, is available years 3 through 5. That's that per Benny payment. Again, that will be set by HSCRC. They're calculated on a per month basis, but paid in the first month of each quarter. And that'll be based on the latest available beneficiary counts with a true up of sorts to final beneficiary counts in future quarters. And those per Benny amounts will be set separately for dual and non-dual bennies. And then we are looking at an add-on payment for beneficiaries who meet certain criteria. We were looking at some of the data around individuals that are lacking primary care, but that's not shaking out exactly how we thought. So we're thinking about an add-on payment for high-risk patients. So more to come on that, but there will be some sort of add-on payment on top of the per Benny payment. And in that same vein, we're really currently trying to set the per Benny amount, and we've had some discussions recently looking at existing primary care models, looking national models, looking at MDPCP per beneficiary per month payments to try to set that amount. And we're looking generally in the area of around $20 for that per Benny amount, but there will be further discussions around that, and welcome folks' input and thoughts on whether that amount sounds adequate or not enough or too little or whatever. So again, maybe at the end we can talk about folks' thoughts on that 20-ish amount for the per Benny payment. And then the shared savings, again, available years 4 and 5. That amount, those amounts will be set by HSCRC, and then again is upside only, like as an EQIP currently. Attribution, no real changes since the last time we talked. We're still planning to use a methodology whereby beneficiaries are attributed to a primary care provider when that Benny has their first claim for an annual wellness visit or welcome to Medicare visit during the performance year. Trying to keep that pretty simple. And this is similar to MDPCP and the new Making Primary Care model attribution methodologies. So we think this is a fair way to attribute the beneficiaries. And I think one of the questions, again, and maybe we can talk about this at the end as well, is whether participating practices or organizations are interested in an estimate of beneficiaries for their practice. We would be happy to provide something like that. So we'll be looking for feedback on whether I think folks would find that helpful. The model of care has not changed. Still, we'll be looking to see that applicants are able to say how their program will align with this, not matching exactly one for one, but saying how they will build care management, chronic condition self-management, support services, how they will strengthen connections with specialty care clinicians. So this will be something that will be really important in the application to make sure that they are aligning with this model of care framework. Okay, so we've built out the participation requirements a little bit more. So I'm going to talk through these points. So participating practices will be required to identify a lead care partner similar to EQIP, who will sign an agreement with the CRP entity and comply with all applicable requirements. That lead care partner won't have to participate in EQIP primary care, because we realized at the time that this arrangement needs to be signed, they may not have recruited physicians for participation in the program yet. So this will have to be someone who the organization identifies can sign and sort of be that lead care partner, but again, don't have to participate in the program. So more to come around that. And then that lead care partner will need to meet CMS quarterly vetting and certification requirements. New sites and providers. This was a suggestion from folks in the last stakeholder meeting. We think this is a really great addition to the program. New sites and providers will be required to participate in Medicaid and register their sites. We think that's reasonable, and given that these areas are underserved and have a high Medicaid population, that this makes sense. And then, as with other similar CMS programs, the use of CMS secured cert will be required as well. We are still discussing the TIN requirement. We understand and realize that this is a complex issue, and how we identify that a practice or an organization is actually creating new primary care, that the TIN requirement may not be the only way or the best way. So we hope that we can be flexible with that. And when the organization comes in, we will assess and figure out the best way to measure and assess, again, whether there is new primary care outside of requiring a TIN as the way to measure that or to determine that. So more to come on that. And then I think the other just requirement that might be obvious is that practices must be in one of the tier 1 or tier 2 focus areas to participate.
So, Krista, we had a couple questions in the chat. I think you covered some of them, but one was, is the lead care partner an individual? And what do you mean by quarterly vetting certificate requirements? And then there was another question, is the lead care partner similar to the CTO in MDPCP, which it is not, but I'll let you go ahead and answer those.
The lead care partner would be a physician that's identified by that organization to sign the agreement. So that would be a physician. And then they have to meet the vetting and certification requirements required for all EQIP for all of the programs that the Medicare, any type of Medicare program. So we can send more information about vetting and certification, but that's a pretty standard process for any participants or NPIs, physicians in these programs.
And it's just, we use lead care partners in all the current EQIP bundled programs. Yep. So each EQIP entity has a lead partner, and that's what it's more akin to. It's not akin to the CTO.
It's not, right. And we're trying to use the same language and the same type of framework, right? So that might be a little bit confusing in the context of this, but that's right, Jean.
And I think Bob asked earlier, and I think you answered this, but I don't know if you want to add anything. He asked, what determines if a practice is eligible for an IP payment in years 3 through 4?
What determines?
Yes.
We are still trying to assess that. I think that will be one of the things that we're kind of fleshing out over the coming weeks as we get the application finalized. But I think that will be based on need and whether they're able to grow the panel of patients. And I think there'll be, folks have thoughts about how we determine that, or at this point, we don't have like set criteria of how we will determine that.
And then Dr. Motormast asked, what does CRP stand for?
Oh, I'm sorry, the Care Redesign Program,
Yeah.
which is one of the main programs under the total cost of care model that EQIP, ESIP, EQIP Primary Care fall under. Yeah, apologies for the
Yeah.
acronyms.
There are three major programs that every one of these types of things fall under. Uh,
Yep,
CRP, MDPCP, and what's the other one?
global
Global
budgets.
budgets, of course. The
Yeah,
big one. So you can
the
tell
big
that
one.
you can tell I'm physician focused. Anyway, all right, go ahead. So
Yes.
those are the questions. I think we're caught up on the chat questions.
Okay,
Hey,
great.
Krista,
Yeah.
this is William. I just wanted to, on the question about the evaluation of the payments, I
Oh,
mean, I
yeah.
think our broader goal is that we don't want to eliminate a practice based on their financial request. If you put together the best non-financial proposal, then we will try and work with you. Where I think it will become more difficult is if we get, three very good proposals and one of them asks for three times as much money as the other two, then that's where it comes to. And the other thing is ultimately, right, we do have a limited budget in this program.
Mm-hmm.
So if everybody asks for a ton of money, we're going to have to bias towards the people who ask for less money in order to work the program. So
Yeah,
that's kind
thank you
of
for
level add
clarifying
more,
that.
but thought I wanted to
Mhm.
add a little bit more of the criteria we're thinking about.
Yes, thank you. Um, okay, and I don't think any of this has really changed from the last meeting, but again, there will be an annual progress report whereby the organizational practice will attest to and report on certain requirements. As you can see below, we want to make sure the practice is open, operating, has staff. And again, if those things aren't happening, we'll need to assess whether they will receive future funding. So that progress report will really be critical in determining next year's funding and also, is the fidelity to the model of care. Are they doing the things that they said they would do in their model of care? And then the quality reporting, there will be no quality reporting in the first year. And we'll be working with practices to develop a framework similar to MDPCP as we've discussed prior, and that an MDPC-like reporting suite will be made available through CRISP to the practices that participate. Okay, and the big one, we got lots of questions about MDPCP, and I've worked with Chad and Alice in the PMO to really target a few really key points that we see as we're starting to flesh this out more. But the MDPCP interaction, one of the key items that we've determined recently is that the MDPCP practices will not be eligible to receive the per Benny payments. They will be eligible for the infrastructure payment and the shared savings, but that per Benny payment is duplicative of the care management fee that MDPCP practice or the per Benny or the per Benny PBPM that MDPCP practices receive currently. So, but again, they will be eligible for the infrastructure payment and the shared savings. And the transition to MDPCP, as we've discussed, it will be required at the end of the pilot as appropriate and as whatever MDPCP looks like under the AHEAD model. So, some of that is still, being negotiated or will be negotiated as part of the AHEAD negotiations. And then practices can transition sooner as appropriate again if they feel as though they're ready to move to MDPCP. And we've worked with MDPCP folks to approve that and make sure that that's okay. So, and then I think the other key item here is that existing MDPCP practices will be expected to continue in MDPCP. We don't want practices hopping from MDPCP to EQIP primary care. This is really, if you're in MDPCP, you're on that trajectory, you're providing that advanced primary care, and this is more of an on-ramp to MDPCP rather than MDPCP moving from MDPCP to EQIP primary care. And next steps, so the next subgroup meeting will be on May 15th from 11 to 12 p.m. In the slides that were sent out, this next bullet was incorrect. The application will be distributed around May 13th and will be open through the end of June. I think there was a typo in the slides that went out. And so we'll potentially use that May 15 meeting to answer questions if folks have questions and are ready to discuss, or tentatively setting another meeting for June 5th, where we can also do some Q&A and have further discussions with interested organizations. So those will be opportunities to talk through the application. And again, reviewing the application in July, applicants will be notified the end of July, and then enrollment in the EQIP portal will happen through the end of August. And that's the end of the presentation. Questions, submit to our mailbox, please. And we are building out the CRISP website for this program, so the link is also here. And then there are a few items in the appendices. So we have again, the zip code list. And then I've also included, and I apologize, this is very tiny on this slide, but the HCPCS codes that are included in how we're identifying the primary care, how we're doing the primary care attribution.
All right, I see we have one more question in the chat about existing practices with new TINs and whether they're eligible and how we're doing that.
Existing practices with new TINs.
Mm-hmm. Go ahead, Dr. Motormass. It was your question.
Yeah, so I'm just. You want to say more? Yeah,
you're muted.
You're on mute.
How many times does somebody have to tell me that? Anyway, sorry. My question really is, so last time we said it maybe had to be a new practice, and it sounds like this time we're moving from it doesn't have to be a new practice, but it might have to be a new TIN. And then the next slide, it looks like said, if it is an existing MD-PCP practice, if you bring those new patients on, they would get the shared savings and the infrastructure, but not the per member per month. Is that correct? Am I summarizing correctly?
Yes, that is correct.
So no longer it has to be a completely new practice.
No, I apologize.
It's in tier 1 or tier 2.
Yeah. I mean, it can be a new practice. It can be an existing practice if the existing practice is adding new MPIs and creating that new access. So we have to figure out, instead of a new TIN for that MD-PCP practice, what does that look like? And Alice and Chad can feel free to jump in. As I understand it, the only way that can happen at this point is if the MD-PCP practice opens a satellite office. So we would need to kind of think through what that would look like. But yes, and please, Alice or Chad, correct me if that was stated incorrectly.
Yeah, I think my question was a little confusing because I said TINs and I meant MPIs, so I apologize.
Oh, okay. So your question, is your question answered? Okay.
Yes, thank you.
Sure.
But I think the goal and the review committee is going to look at new primary care. That's the goal. So if I think the selection committee is going to understand the goal of the program, and if someone's coming in and trying to game the system in some way, that will be looked at with a jaundiced eye. Is that correct, Krista?
Yeah, I think we want to make sure that, folks aren't just trying to get the money and aren't expanding access or creating new access, right? So we'll be scrutinizing that to make sure that's not happening.
Okay. Go ahead, Natalia.
Thanks, Jane. Hi, everybody. I'm the Senior Policy Advisor here at the Johns Hopkins School of Nursing, and we're working on that neighborhood nursing model that you noted in the presentation. And I think, we're partnering with the other schools of nursing here in Baltimore. We're piloting this neighborhood nursing program, which I'm curious how you might consider in terms of, we're putting a nurse and a community health worker in many of those zip codes. We're already piloting here in Baltimore. We're looking to expand to rural areas, and some of those zip codes included in your presentation here today. And I wonder if, if we work with some of these practices, adopting this model to help do a lot of the care coordination, improve access, and extend coverage of the primary care practice and bring new people into the practice, even if they're not building new practices in brick and mortar, how the HSCRC would look at that opportunity as a way to expand. And we see that as a really great model to do that. We're learning a lot right here in Baltimore in terms of even people who have primary care down the street aren't using it. And so this RN community health worker dyad is actually doing a lot to improve access for people who either have lack of trust or other barriers. Anyway, so I wanted to bring that up and also offer folks to reach out to me if you're interested in working together and thinking you might partner on.
I think we'd be interested in when folks that are applying to tell us how they see that working. I think
Chris, isn't there one practical problem? You have to be one of the practitioners that's covered and participating under Medicare. So if they're using community health workers and RNs, they can't bill Medicare. So Natalia, I think you could obviously partner with people, but unless you have a biller, it would be difficult. So
we couldn't apply as a practice.
Right. I'm going to tell you what I would suggest is why don't you sound like a very, very good community partner. So why don't you send me your info and contact and I will share it. We'll have Olivia or myself share it with everybody in the group. And I think that it would make perfect sense to have you partner with some of the applicants. And there might be a way to do that. And that'd be very logical and very helpful because if we're doing this, you're going to have to build out, care management capacity and other capacities, and you have it existing and you'll want to do it. So I think that's a really good fit. I don't know, Krista, do you have any?
Yep, agree. I think that's appropriate. Yep.
Yeah. So just
I'll send you a written sort of info sheet about the program and my information so folks can reach out. Thanks, Jean. Thanks.
And I just put my email in the chat if you don't have it. Okay.
Great.
Yeah. And Natalia, if you could send that to me as well, that would be great.
Will do.
Yeah, and then we had a clarification question from Marcella. Just to clarify, existing practices can't participate unless they create new capacity through not through new NPIs, not just capacity in existing practitioners. And that is correct. So yeah, you got to do new. So right.
Jean, Howard, I have a quick question for you. And if a practice is in the application establishing a new TIN, and will they be able then to use the history of care delivery and other resources that the TIN original owner of the NUCO's TIN was providing historically as evidence of capabilities under the scoring rubric for the application. In other words, if you have a new TIN, it's going to be absolutely new, so there won't be any history of that TIN's experience. But you can use vicariously whoever the lead care partner's experience.
Yes, absolutely. Yes, I think that's regardless of the TIN. Yes, their experiences we'll want to know that regardless of whether it's a new TIN or not.
So Dr. Motormast asked if a lead partner could be has to be an MDDO. They do not have to be an MDDO. It just has to be someone who bills Medicare who's participating in EQIP. And if you go into one of the existing EQIP entities, you can see, for example, the MedChi orthopod lead care manager is Dr. Koda, for example, and he's the one who's principally responsible, and he signed the agreement, and then he works with the others. So you could certainly use a nurse practitioner who bills Medicare and participates. It's not a problem, Dr. Motormast. And then Marcella asked Will Henderson if the new NPIs have to be dedicated to this program only.
So I'm going to answer that and answer something. I think we would be open to a scenario, and it makes some sense to say, okay, I've added 2 new NPIs to a 6-doc practice, but I want, I can't only have the new NPI see the new patients, right? I want to use all my docs. I think we would work with somebody to figure out how we do that, right? If you're saying, well, the new patients might see any of the 8 docs. I've added 2 new ones, but they will share the practice. So I think we'll work with that. So I think the answer is no, the new NPIs don't have to be dedicated. That said, the simpler your story is, right? The easier it is for us to score, the more I think it's going to make sense to the practice. So we want to try and balance that.
I will say this, Will, and I do think that some flexibility with regards to that does make a little sense. If you think about some of the areas on the shore, for example, in Dorchester County is a tier 1, a large portion of Dorchester, for example, you might need to have a plan if you're opening a new practice on how you're going to make it viable, where maybe a new half an NPI can do this, and that new half an NPI can do other carriers to make the thing work. So you might need to be able to do other work as well to make the whole thing work, even with the subsidy. Does that
Yeah.
make sense?
No, I think that does make sense, and that's why we're open to that. I think where we get a concern is where you're saying I've got 50 practices and I'm adding 2 more to get to 52, and
Right.
it becomes
Yeah.
it becomes difficult for us to then isolate whether that's just any change. Um,
Can I ask one other practical question that I brought up earlier in the process, but I think is important to consider again? What I'm concerned about is in some areas, if we have people who are planning to do something, it's obvious, if you're in Washington County, obviously, if someone's planning on doing something, they need to talk to Meredith, and you might know who to talk to. But in other areas, it might not be as clear. Are we going to have some kind of process where if we get people who are interested, or are we going to have a letter of intent process so we can connect people together if they're in the same area, so we have a better application for that area? Or are we just going to take applications?
I mean, I guess, I don't know, William, what your thoughts are. I don't think we were planning on a letter of intent. Maybe if folks want to just, maybe not a formal letter of intent, I mean, they could certainly reach out to you or me, or we could try to, make those connections. I don't feel strongly either way.
Well, it just seems to me that, for example, if we added a level that was, if you plan on applying, you have to submit a letter, and then when you submit the letter, you say whether you'd like to be shared with other people who are planning on applying for the same area. It does two things for us. It lets the HSCRC know if there's a potential major budget problem or an issue. And then if the people who put the letters in say they're willing to have their information shared, then we can create partnerships so we get better applications for those regions. What I would hate to have happen is, for whatever reason, we get 3 applications for Dorchester that are all okay, and then we end up not doing any of them because none of them are as good as others. And if we got all those groups to work together, we'd get, I'm keep picking on Dorchester, it just popped in my head because it's the biggest tier 1 area. But anyway, my point is that I just think we should foster partnership if we can. So I don't know how you feel about that. I don't know if anybody else has feelings on it, but it just seems to me that it might create a better situation.
Yeah, I think we could be open to including something like that in the application, where we just kind of ask people to register their interest.
Does anybody on the group have any major concern about that? Okay.
No, I think that collaboration would be helpful with this. I know the CTOs have been helpful for practices transitioning their care and all that. And I think being able to have, a couple groups working together rather than nobody getting an award, that'd be I mean, if we're really trying to maximize primary care, probably get a lot more bang for our buck that way.
Yeah, I think that makes sense.
The other benefit of that is we could have people like Natalia just do a letter of interest saying we'd like to work with everybody. Here's what our capacity is, but we're probably, and then we could just share that with everyone. And that would give other people who want to partner, but maybe don't want to do an application or don't have all the pieces to let folks be aware of it. I just want to make sure that everybody's working together and we get the best outcome of this,
Great.
Any other questions from anyone? Krista, anything else?
I see one in the chat. If an existing MDPCP practice sets up a new TIN, won't this impact existing MDPCP attribution? I don't know if Chad or Alice want to speak to that.
So Kimberly, here's my understanding of that. And immediately it will not, because that physician will not be in MDPCP and it's each physician. Now, if that practice were to then add the physician to MDPCP, and there is a process when a practice that is in MDPCP adds a physician, they want to add the physician in, then obviously they'd be treated as a new MDPCP participant in the next year. But if you were, for example, if you're to add a physician today, the patients who are assigned to them do not go to the other physician patients in the practice. That's my understanding of how it works based on dealing with the practices in the MedChi CTO. So in the long run, yes. In the short run, no, is the answer to the question.
Okay, and we'd have to make sure that that patient consistently sees a non-MDPCP provider at the practice and doesn't go between MDPCP and non-MDPCP providers, right?
Why? If it's a new, Gene, I think if it's a new TIN, they can't bill Medicare. The same practice can't bill Medicare the NPIs in that practice can't bill Medicare under two separate TINs. So it can't be a new TIN in MDPCP.
Oh, you're right. Yeah.
It violates the contract.
And I guess what would
Right.
happen is then what would happen is the patient would be attributed based on who they saw more, and MDPCP has a process, and this will have a process, so it'll land based on whoever they're seeing more.
Mm-hmm. Right.
Kimberly, you're pointing out a complexity. And actually, my scenario deals with the group that adds the practice and doesn't change, adds the NPI and doesn't change the 10. My answer really answers that problem, which is also an issue that someone who's doing it needs to consider. Anyway.
Yeah, I mean, that's the basis of some of my comments previously about, you know, a new TIN is a new practice. And, you know, just hearing what's been going on here, it really seems there's a direction, a vision, a passion for brand new practices, because really a TIN represents a new practice. It's like saying, oh, we have the Primary Care EQIP. We're going to create a new healthcare commission to monitor that. We don't want to muddy the you know, tracking of that under the HSCRC. Let's just create a new commission. We'll just get the governor to appoint some people in legislature to do it. It's that complicated for a small practice to do a new TIN. So I really think that, you know, everything I've heard in these discussions really are focused on, you know, new primary care in new areas where it's really underserved. And, you know, if that's the target, then shoot for it, you know, be aggressive with it. You know, but now we've got some very small geographic areas where it's eligible to have a new practice. And then if it has to be a new practice and you don't want to redistribute a doctor from, oh, I'm working over practice A, now I'm going to start practice B, and my patient's going to follow me over there. Well, now we need to have a new physician come to town. Well, how many new physicians or providers are going to move to the state after applying for this and getting a license and getting, you know, going through all the onboarding with payers and so forth. So, you know, nonetheless, it's very complex to start a new practice. And it's even more complex to try to, you know, create this new TIN under the guise of an existing practice, and the attribution and tracking and contracting with payers. I mean, it all starts new. You have a new TIN, you're a new entity. You have to get reapplied all the payers and all that to be a participating provider. So we initially start out, you're a non-participating provider. So at any rate, and I guess that's the purpose of having some of the subsidy funds, was to allow to bridge that initial gap in revenue that you'll have as you're a non-par provider with all the payers. So,
yeah, I mean, I think I would characterize it a little different, Ken. I think we have a passion for getting new providers into the target areas. You know, I think there are hundreds of scenarios in terms of participating in MDPCP, new practices, new TINs. Ultimately, we're thinking like 3 to 5 of these. So I think we're willing to work with the successful applicants to figure out the best setup.
Yes.
We can't account for every possible scenario, and I don't think we need to, because we're not going to have hundreds of scenarios, right? It's not like standard EQIP where we have 3,000 physicians, right? We're talking about a very manageable number. So I think we would encourage people not to worry too much about the new TIN, new NPI. Propose something that brings new provider capacity to a target area. If we like your application, we'll work with you, whether it's a new TIN or not a new TIN, whatever works best. Because I can see plan A working for practice A, and plan B working for practice B, and plan C working for practice C. And since we think we're talking probably about 3 to 5 statewide, we're willing to customize, basically, in this case.
Wow, that really is great to hear that you're, you know, looking at this on, you know, critically by scenario, as opposed to trying to create a one-size-fits-all inflexible standard. So I think there's a lot of wisdom in that. I think that's a great way to administer this grant. And I think that gives you the best chance of really finding some winners out there to meet primary care needs. So I really, really appreciate you saying that. Thank you.
Good.
Thanks, William.
All right, good discussion. Anything else from anybody? Last call for questions. Oh, one more, Dr. Motormast.
I just want to echo what Ken just said. I think it'd be great to put something like that in the slide deck, that you're open to options. and these are the needs. You know, you want new providers and new patients that are coming from the areas that you're showing on this map, and that if you have an idea about it, to let you know. That way, when this information gets shared, maybe people aren't saying, well, this isn't a fit for me, I can't do that. So just to let people know that there are other options available.
Yep. We can definitely do that.
Okay. Anything else? All right.
Someone trying to say something?
Sounds like we're good. All right.
Krista,
Well,
can you share this recording?
Well, actually, we post the recordings on the MedChi website. It'll be under medchi/equip, medchi.org/equip. And you can look at the other two too. So
Yeah. Okay.
And
I think they'll also
I will have it up by the end of the day.
The trilogy.
Yeah. No, thank you. One of my colleagues
Chris.
couldn't make this, so thank you very much.
No,
We're shocked. I know.
All right. Thank you.
Okay. Thank you.
It'll be saved for posterity.
Thanks.
All right, guys.
Take care. Thank you, everyone.
All right. Have a good one.
Thank you all.